All right, everyone, welcome to day 2 of PH646 presentations. I'm delighted to get started with Justin. Whenever you're ready.
Thank you, Professor. Hi, class, and thanks for your attention. My name is Justin Fatui, and today I'm going to be talking about my research question, which revolved around taking a look at medication-assisted treatment centers and the impact it has on substance use disorder outcomes. So just to give a little bit of background on the opioid crisis. So obviously before COVID-19, we're all familiar that America was suffering greatly from the opioid epidemic. Now, this is a multidimensional issue that has impacts felt throughout the US healthcare system. It's felt on a personal level. For example, in the year of 2018, 130 people died each day because of opioid abuse. And then also in the same year, 2 million people were diagnosed with opioid use disorder. And studies show those with opioid use disorders utilize a lot more health services. There's another background to the opioid crisis is its extremely high cost. As healthcare leaders, the opioid epidemic has really impacted our system in the United States. And I think it's up to us to try to think of and analyze ways to attend to those problems. And one of those is by diverting or is one of those by pointing our attention to things future and forward-thinking methods such as MAT centers, which I'll get into a little bit. But as far as the costs, the Council of Economic Advisors in 2015 estimated the epidemic to be $504 billion. Now they account for fatal costs and non-fatal costs. Fatal costs, of course, is the loss of potential earnings, and non-fatal costs deals with the money we spend on criminal justice and as well as healthcare spending. Now, to address that, so now that you have a little bit of background about why it's so critical, let me tell you why MAT centers are kind of the point of topic at this point. Medication-assisted treatment essentially serves to normalize brain chemistry, block euphoric effects of opioids, and essentially normalizes body functions without the negative euphoric effects of substance uses. This is a different method from our traditional inpatient detoxification services, which end up costing a lot more and have less impact on the patient and society. MAT centers have been shown through my literature reviews have been shown to increase retention in treatment, increase ability to maintain employment, improve birth outcomes among women who have substance use disorders, and decrease illegal activity by lowering the illicit use, but above all, improving patient survival. So now, because of this, I'm going to take a look. My method was, or what I aim to do in this study is to observe the frequency of MAT centers available and determine if a higher frequency of MAT availability leads to lowering certain substance use disorder outcomes. This is a county level comparison in the state of California. What I did was I used the SAMHSA database, which allowed me to, which had a tool for MAT locators. And they gave me, and what that did is gave me the number of MAT centers in each county. Now, I used census data to format this into MAT centers per 10,000 people, also known as adjusting for population. So doing this allowed me to avoid interpretation error, and it helped me to make valid comparisons, as you will shortly see. Beyond that, I utilized the California Department of Public Health opioid dashboard, in which I was able to retrieve some of my main outcomes and covariates. And also those were as well, adjusted for population. Here is a look at my descriptive statistics of California County substance use disorder outcomes. You'll notice my main variable, I'm going to explain some of my main variables. Opioid deaths is the death related to any opioid overdose. ED visits are emergency department visits related to any opioid overdose. Hospitalizations are hospitalizations related to opioid overdose, and then RX are prescriptions for opioids. My variables are presented per 100,000 residents. But for MAT centers is represented per 10,000 residents. Now, you'll notice my county size. I analyzed a total of 16 counties and separated them into small, reformatted them into small, medium, and large for to help with my analysis, which brings me to my table 1. The cross tabulation of county size and outcome variables. What you'll notice here in the highlighted portion is fairly significant values here for my opioid death outcome and also my ED emergency department visit covariate. So what you'll particularly notice, and what I will further point out, is that medium-sized counties struggled with variables such as opioid deaths and emergency department visits compared to smaller and larger sized counties. Now, I'm going to give a closer look here. I'd like to first direct you to an ANOVA distribution plot here, where I utilize this code and Parway code to give me an analysis. It was an analysis feature, and so it was classified by my size of county. So you'll notice at the bottom, I've classified my county size as 0, 1, and 2, which translates to small, medium, and large. And what you'll see and what to get out of this is the distribution of the MAT center or the MAT centers. So what we'll see, what we could get out of this graphic is basically observing that medium-sized counties in particular are struggling a little bit with their with the frequency of their MAT centers comparing to small counties and large counties. Now, this is significant and something to remember as I move a little further here. And this is just the Wilcoxon scores for MAT centers, and this is a better kind of visualization of how you'll see my medium-sized county county group is struggling compared to the small size and large size, as you'll notice here. So, and the Wilcoxon scores kind of offer a highlighted point where you would expect the score to be 42, but the sum is actually 31, signifying that they are struggling a little bit in terms of the MAT center availability compared to small and larger size counties. Now, excuse me. Oops. Sorry about that. Now here you'll see the ANOVA chart for the emergency department visits. And this is kind of where this is where it kind of gets interesting, because there seems to be a trend here where we just went over the fact that medium-sized counties are struggling to keep up with the frequency of their MAT availability. So now I'm checking out their emergency department visit rate. It seems that they have a higher than expected score in terms of how many people are visiting the emergency department due to opioid overdoses. And to couple with that, looking at the opioid death rates, we actually see a consistent trend from the emergency department visits, in that medium-sized counties are still struggling because you'll notice that they have a higher than expected score thanks to the Wilcoxon analysis, which essentially portrays that they particularly have a higher opioid death rate than expected, or than expected, related to opioid overdoses. And at the bottom right, the p-value of 0.08, I classify as significant. However, I understand it's not below 0.05, but I believe that with a larger pool of analysis, I could actually strengthen my significance value and possibly get it, possibly see a value below 0.05. But for my purposes, 0.08 is still significant.
Okay, you have about 30 seconds, Justin.
Thank you. So in conclusion, I really need to include more counties in order to make a stronger correlation. As with a lot of our projects, this experience has been really informing. However, I understand that in order for me to really make a suggestion, I need to include all the counties in California. Presently, there is a comparative lack of MAT frequency in medium-sized counties. Furthermore, I observed that medium-sized counties are struggling comparatively in terms of their opioid death rates, as well as emergency department visits. And that is where I am at this point. And I hope to continue this research to include more counties to get a better idea of, if there really is a correlation of MAT frequency and substance use disorder outcomes. Thank you.
Very good. Very good. Thank you, Justin.
Thank you.
All right, clarifications, questions, comments.
I had a question, Justin, and it was about whether or not these centers, or like if you knew whether or not these centers like provided like Narcan, or also known as naloxone, to the community members, because I know that there's some programs out there that give out Narcan to different people. So I was wondering if you had a chance to look at that at all.
Yeah, that's really, yeah, it's really interesting question. So my understanding is Narcan works best to reverse an immediate overdose. So at the moment, so less so as a planned treatment, or less so as a treatment plan, but more as a use for emergencies. The question is if whether these MAT centers offer them. I'm not particularly sure if that's the case. However, I wouldn't be surprised if they did. But my understanding of Narcan is it's for the immediate use to revert an overdose that is happening at the current time.
But maybe not necessarily part of the MAT regimen or treatment.
Yeah, but still an extremely useful tool and very important in terms of fighting the opioid epidemic.
Okay. Thank you. Oh, hang on. Sorry. Go ahead and ask another question. Any more questions? Nobody has any more questions or clarifications? Okay, I thought he was I thought he was done. I have a question.
Hear me at all?
Sorry?
Hello. Hey,
Is
so
there a
Luke here.
question?
Yeah, can you hear me okay?
Yes.
That's a yes? Okay, yeah, I'm driving, navigating a couple different things. I can speak to that a little bit, the question of like Narcan. So when you're prescribing anything containing buprenorphine, usually naloxone is part of that prescription. So you're prescribing, maybe it's like Suboxone. So that's like the actual MAT medication. Naloxone's part of that. but oftentimes you do give people Narcan as well because there's still a risk of relapse. And if people relapse, especially after not using something like heroin for a while, then their tolerance goes down and they're at a very high risk of overdosing, like if they go back to using the same doses that they previously had used. My understanding is, to put it simply, like every MAT program that I'm aware of in the state, including us at Father Joe's, they all give out Narcan to anybody who's prescribed MAT.
Yes. Yeah, totally. I
Excellent.
totally think it's really important to include Narcan.
Well, and I mean, even though most MAP programs may vary, that seems like there's some fundamental elements that it's good to know. Let's stay more closer to the structural elements, just in the interest of time. So one more question or clarification. Okay, I have a question. First of all, why did you choose the 16 counties? You knew that was coming.
That's a convenient sample. It was a convenient sampling.
Okay.
Yeah.
So you're planning to include all of them, right?
Yes.
Excellent. Okay, and then are you aware, aside from the regular detox centers, of other alternatives to MAT centers that you may be excluding from your study?
That is something I have been thinking about as well. That's a factor I want to study a bit more in terms of the future, just in case I might be leaving out potential availability of MATs, which would be critical to my conclusion.
So much like FQHCs have FQHC lookalikes, and and this is everybody, what's the first place we would look when we want to find out this information, this type of information?
PubMed?
The literature, yes. Very good. Thank you, Justin. Good job.
Thank you.
Uh-huh. All right. So Jefferson?
Yes.
Right.
Okay, cool. Share my screen. So I did a video. So please let me know if you all can hear this.
Okay.
Jefferson, and this is gonna be my.
Hang on a second. Hang on.
Yeah, Jefferson, we can hear it.
Cool. I'm just making sure.
Okay.
Let me know whenever you're ready, Dr. Shakina.
Yes. Yes, whenever you are. Sorry.
Cool. Then I'll start playing.
Hey everybody, this is Jefferson, and this is going to be my PH646 final project presentation. My presentation will focus on the data to information, the information to knowledge, as well as the knowledge to action, where of course I'll be building on the background literature review, the methods, study design of the data set, show my tables and figure, as well as the conclusion where I'll just be talking about the strengths, limitations, as well as implications, as well as what I've learned throughout this whole entire process. For my research question, I'll be focusing on, is there a difference in the delays of medical care in the last 12 months in hospitals when comparing racial populations? Why this was significant was because of the fact that approximately 16 million Americans were unable to get needed medical care in 2001, and another 26 million delayed getting care they needed. A potential reason for that was because of the fact that patient-physician relationship could be an important factor in preventing unmet needs and delayed care, but is poorly understood. And an example of why this was needed was that because of the fact that African American women are twice as likely to suffer from pregnancy complications and multiple comorbidities than white women. For the literature review, it did show that there was delays in care, as well as why there's a need to consider it. But even when conducting the literature review, they all had different study methods that showed of the end result. One of the three study methods being looked at was that the logistic regression model, the retrospective cohort study, as well as interviews. For the logistic regression model, Trust was shown to be a commonality of importance of showing that there were trust in physicians can negatively negatively associated with delays in care if there was a lack of trust between the physician and the patients. And similarly, in the retrospective cohort study, skin tone-based mistreatment and racial discrimination in the form of microaggression can influence care received by patient as well as affect the outcome of care. For the interview article, barriers to cause an increase in delay of care in non-Hispanic Black patients in comparison to non-Hispanic whites were found to be larger due to low socioeconomic status and increased travel burdens. So by increased travel burdens is the distance in which to receive care that should be considered when looking at the report's data. For the data set, I looked at the CHIS data set, which was the California Health Interview Survey, which is the largest state health survey in the nation. The survey is conducted yearly and sampled extensively to be statistically representative of the California population yearly. The research I'll be looking at focuses on the 2016 adult data set, which had 21,055 participants. It was representative of my research design, sampling, and population of interest just because it was representative of the people in California, as well as looked at delays in care, which was my primary outcome variable that I wanted to analyze. For design and framework, for the CHIS dataset, it was collected January to December 2016. It was a mixed model survey, which was conducted by web and telephone, broken up to 3 age groups: children, adolescents, and adults, which was the population I was looked at. For my research study design, I conducted a PubMed search to look for literature to help with the literature review for the research, as well as recorded the variable for age group from the CHIS dataset to better read the data in my research analysis, which would be shown on the table 0 and table 1 figures. For the framework, I conducted a Donavian framework, sorry if I butchered that, to help build out my research question. The structure, of course, would be the hospitals. The process would be the step-by-step of how care is determined and carried out, as well as the outcome is if there are delays in medical care for populations. Table 0 and table 1. Key things to note is that, of course, for the age group, I did recode it so that there was it focused on 4 different age groups rather than, I think it was the 13 they had previously. As well as another thing to note is that there was more no's in which patients said that there was not a delay in care than yeses. But the key thing to note is that it still showed that there is a need to look at it, as well as to consider why there is need in care. And similarly, you can still see that whites in itself was still had a higher representation in the data set that in comparison to other populations, and that should be considered when looking at my findings. For the figures, I used a categorical histogram to represent the findings to show that whether or not there is a yes delay in care or no, there was no delay in care. And even then, there was more no overall in the racial populations than yeses. But there's still a need to consider that the primary population being looked at was the whites and, rather than the other racial populations. From the findings overall, the literature findings show that there is a need to consider the racial populations in delivery care, but the results found that there were fewer delays in care overall. The research findings show that whites had a higher number of responses for both receiving care as well as having delays in care. In the discussion, as stated earlier, the findings did not agree with what I hypothesized, where I thought that minority populations overall would have significant delays in care than white racial populations. The literature, however, did agree with my hypothesis. The results found that from this article that there are still instances of delays in care that should be looked at, as well as to understand why there are delays in care. between the racial population overall. The information still poses the question of why there are delays in care and what should be done by health organizations to improve these findings. As stated earlier, there still needs to consider why different racial groups had delays in care, as well as what could be done to better diversify the responses and what should be done to better improve that there is not delays in care overall. For the action and decision making, this research could be beneficial to look at as a way to look at California's sample distribution of delays in care, as well as could be used for comparison, so that this could be used as a baseline to look at specific racial population groups and to allow for comparisons to be made. For the strengths and limitations of this research, the strengths, of course, is the data population. The CHIS data set was, of course, representative of the California population. It was conducted yearly, so extensively, so it was statistically representative. Of course, it was cost efficient just because I used secondary data through the CHIS data set, so I did not have to spend any money when carrying out this research, as well as how much it can be applied. This research in itself and my findings have future implications to hospitals to look into reasons for delays in care that would further expand on my initial research findings, as well as look into my hypothesis of if minority populations have more greater delays in care. Of course, similarly, because the cost efficient of the secondary data in turn also has limitations, just because I was limited to the set questions and answers that the data set had, as well as the time constraint of how long I could work on this research question. Overall, the lessons I've learned is that there is always a need to consider the data source and how it can be applied. The literature review in itself is an extremely long process, so it should be considered. In all aspects of the research question, and as well as it's a continuously evolving method of research. And similarly, always start early when answering a research question, whether it is the background, the coding, or the data analysis, as well as ask for help and have a second opinion of what is being done, as well as the quality of work. So pretty much that concludes my research presentation. Does anybody have any questions? As well as this is my references of what of the articles I looked at, as well as how in relations to my research.
That sounds like you're talking. I love it. That was a good recording. Like the others, you could kind of tell it was recorded, but this one. All right, questions, clarifications, comments. Anybody? Nobody? Hello? Uh-oh, I think.
I don't have a question, but I did think it was really interesting that your hypothesis was supported by the literature, but not by the data. Like, I feel like you often see that it's like either completely unsupported or completely supported. So it was interesting to see that and that you were open about it.
Yeah, it was an interesting. I didn't really think about it until like towards the end when I was like actively looking at it, because I was like, okay, I thought it would just all support, but then when looking at it, I was like, oh, but it was still interesting, as well as like, as I mentioned earlier, the implications of this is kind of like interesting to see what could be done, as well as like reasons why.
Jefferson, can you go back to your table 1, but zoom way in?
Yes.
And don't ever put 2 tables on one slide ever again for us old folk, because that's just mean.
Sorry. I thought it would like show better when like it's on full screen.
Why do you say it is not significant? Your p-value is 0.0001.
Why is it not significant?
Yeah.
Oh, did I say
Why
that?
are you saying that your hypothesis was not supported? Tell me why you think that.
Oh, it's because I thought there would be more delays in care.
What are you looking at to determine that?
The yes and no of between like the different races, as well as overall.
Okay, so be specific. What number exactly are you looking at?
Oh, so pretty much. So is there the yeses compared to the nos?
Are you looking at the counts or are the proportion?
Wait, can you rephrase that question, please?
When you made that, okay, so remember how I've been acting like a crazy lady waving the flag of row percent?
Yeah.
This is exactly why. Because I wanted you guys, the reason that you do row percent when you're doing a comparison table is so that you're able to compare the outcome, right?
Mm-hmm.
Care delay across each value of your variable. Remember value variable?
Mm-hmm.
So that way, when you go down the column of yeses, you can look at, they should all be the same if there's no difference. It should all be the same percentage. There's differences in the representation of minority populations in the United States as a whole, right?
Mm-hmm.
That's your baseline comparison. So there's about 12% African Americans in the US. There's like 6% of African Americans in California. There's like 30% Latinos, and there's like, you know what I mean?
Yeah.
So that's why we don't look at frequencies. We look at proportions.
Mm-hmm.
And then we compare them down the line. So if you look at this and compare it to, for example, white, 12% of white participants responded and said, we do experience a care delay.
Yes.
13% of African Americans said they experienced a care delay. Who's the highest risk population in this column? Who's the group that was most likely to say they experienced a care delay?
American Indians? Or no, more than one race.
Participants reporting more than one race.
Yeah.
And what this is telling you, the significant p-value, is that in fact, those differences are significant.
Yeah.
Does that make sense?
Okay, yeah.
So in fact, your hypothesis was supported, sorry.
Got it.
Does everybody understand why now the row percent is so critical and I made everybody fix it? Because of ease of comparison. Because now he could just look down the row,
yeah,
and say, oh, that is a difference. Does that difference matter? Apparently it does. Look at the p-value.
Yeah. Okay.
Okay. Same with the ethnicity. Whoever non-Latino other is one race is pretty bad off, and so is non-Latino more than one race.
Yeah.
Because look at non-Latino white and non-Latino Asian, they're doing pretty good. Non-Latino African Americans doing not too terribly comparatively.
Mm-hmm.
And Latinos are doing great, well, comparatively.
Yeah.
But look who's not doing so great. Non-Latino, more than one race, and other race, whatever other means at this point.
Yeah.
And Latinos used to be other, so
Mm-hmm.
I don't know what other is at this point. Okay?
Okay.
Does that help?
Yeah, that makes more sense.
Okay.
Got it.
But I also appreciate, because even if it's not a significant result, even if it's Justin, as what you were trying to say is marginally significant. Less than 0.10 is marginally significant. So it's on the cusp of significance. And you're right about increasing your sample size to help that. I forgot to tell you that. Okay. So yeah, so this is, in that respect, this is something important.
Mm-hmm.
Okay. All right, more questions, comments, thoughts? So and that's also why frequencies are one thing, but if the populations are diverse, you want to do proportions. If you know that the baseline populations differ, if they're not equivalent, then you want to do proportions.
Okay, got it.
So like if you just look at the ends, you're like, oh, I need to do proportions because it's not split. Okay, so and you know what I would love to see on this one is multiple years to see how has this changed over time.
Yeah.
Has it gotten better or worse? What's your hypothesis there? I'd be curious to know what your thoughts are. What if you saw anything in the literature?
Yeah, that's what I was like. That's why one of the things I noted was that it's from 2016, just because of like there's room for like comparisons as well as like of course like this would be like the general baseline. but then go see what could be done there.
Yeah, yeah. But overall, very clean, good presentation. Thank you. I have comments for you too, so I'll write those down.
For sure. Thank you.
Oh no, thank you. All right, who's next?
I can go.
All right.
I recorded mine, so I'll go ahead and share my screen.
I'm glad you guys like the recording option. I didn't know if that was actually even going to be useful.
It was great because then I knew my timing was on.
Okay, hold on.
Let me get myself situated here.
Okay. You know, it's funny because I would never use the recording option, but for some reason I was like, well, maybe somebody wants to record it. They can record it. Turns out it worked out. Sometimes we're literally just making things up. Don't tell anyone I said that. Oh, I just recorded that. I'll get it out. I don't know how to do that, but that's okay. Oh, I can't see your whole screen, dear. Oh, there we go.
Is that good?
Yeah. Oh, I like the research question right there, front and center. All right. Whenever you're ready to roll. I can't hear you. Hello?
To understand the relationship between independent and dependent variables.
Can you go back?
Test my hypothesis. The hypothesis.
You couldn't hear it on the second slide? It stopped?
It worked after, but I just couldn't hear anything for a second. Was that intentional? Was there nothing on the first slide?
There was stuff on the slide. That might be an issue.
Okay, just try it again. It's okay. We'll roll with it.
Or
you
I can
introduce it if it doesn't. Yeah, just intro it and then hit play.
Okay, let me try again.
Yeah, I'm gonna.
Okay, now I had like all my tabs just closed. Does someone want to go before me then?
No worries. Yeah, we'll come back to you. No worries. Yeah, take your time. Anybody else ready to go?
I can go.
What about Cynthia? Okay, Natalie, go ahead. Pop on in.
Sure. Let me get mine up and moving.
I've been having trouble with my Zoom too. I had to restart my whole computer because my video didn't work. So it's just going to be one of those technical days, guys. No worries. You guys have the nicest presentation covers and whatnot. I feel like all mine are like lame. I need to find out where y'all are getting your thingies.
Slides go. That's the best.
Slide scope?
Slides go.
Slides go. Oh, I have to, I'm gonna follow up on that. Thank you.
That one's thank you to Twee. So today I'm going to be presenting about health coverage and influenza vaccination uptake in California. It's a little bit of table contents of today. We're going to go into background, study design and methods, results, and then discussion. So a little bit of background. As you all know, influenza is highly infectious, it's serious, and it really costs a lot on our healthcare system, even though it's a pretty preventable disease with the vaccine. So the CDC's flu statistics for 2018 to 2019, there were 36 million symptomatic infections, 17 million medical visits, and 490,000 hospitalizations for influenza. And there was a total of 34,000 deaths. It was a pretty low year for flu. It was 61,000 the year prior, but it's still a very significant amount of death. There are a variety of vaccines available. You can get a nasal route or you can get an injection. There's some different strains, trivalent, quadrivalent, 65 and up formulations, which is a little bit stronger. And it's recommended for all people over age 6 months. There are some contraindications for previous history of adverse events, egg allergies, and under 6 months of age. So going into the literature, these 4 publications all discussed similar to what I thought I wanted my research question to be about assessing the relationship between health insurance coverage and uptake of influenza vaccine. There were some convergent themes across them. There was a relationship established by most of the literature, and they all used secondary data, which I thought was interesting. The divergent aspects of them was that the populations varied a little bit, the settings also varied a little bit, and the study design.
Nice.
But they all found that there was a clear association between healthcare coverage status and influenza vaccine rates. So this is a little bit of the evolution of my research question. As Dr. Shafino knows, it was a long evolution.
Oh, I love this.
So version 1 is on the left. It was complex, it was too broad, it was lacking data. So it evolved into many versions to the one on the right, which is, does having health insurance increase influenza vaccination uptake amongst Californian adults, which was clear, simple, and had available data, which was.
Bravo. This is my favorite slide, sorry.
Here is the process map of the sampling. So as you can see, I started on the left with the question of, do you reside in California? For those who do not, we excluded from the studies since I used the BRFIS data, which is all the states, and it's aggregated. It's not a national survey, but rather individual states aggregated. So we excluded non-Californians, moved through each of the questions, and you can see they're different type of question based on variable status, and then the end. So as I mentioned, my data set was the BRFIS data from the CDC. I gathered that data, extracted and transferred the California data only to a SAS file, identified my dependent, independent, and covariates, and ran analyses to determine the relationship and significance. This is my table 0. I split it for readability, as you'll see at the bottom. It flows through left to right. You'll see the numbers. You'll see in the graph, so I thought it was very interesting how the numbers shook out. This is my table 1, which shows the relationship between them. It was really interesting to note that all of them were significant. General health status was a little bit less significant, but still significant than the others, but it was very exciting to see that they were all indeed significant. I was most interested, obviously, in the healthcare coverage, but it was interesting to see the other factors that influence that, like source of healthcare coverage, general health status, race, ethnicity, and gender. I wanted to stratify it by age, but BRFIS does not go that granular into age. So that was a little bit frustrating. They only do 65 and up or 65 and under.
Oh, is that right?
Yeah, that was a bit frustrating. And I was kind of sad because I want to see that, but in the next data lifetime here. So this is my chart. You'll see that just the main research question, influenza immunization in California adults stratified by healthcare coverage status. So you'll see on the left, covered adults. These are the people who do have healthcare coverage. Only 47% were immunized. 53% were not immunized, which was a little bit shocking given that insurance plans really advocate for this cheap and effective tool to prevent really costly issues later on. And for no coverage, the difference is even more shocking. 81% are not vaccinated. Then I wanted to go into it to see by healthcare coverage type. Does that impact why people are not getting flu shots? What I thought was interesting, public plans are doing really well. They're better than the average. They're getting the more, rounding up obviously goes to 101, but it should be 51 and it's 49 point something, but it's still barely half of the population. And tribal has a really long way to go because they do have other impacts. So it's kind of sad to see this data laid out. So here's a little bit of discussion on it. I found there was full support for my hypothesis. Having healthcare coverage increases influenza immunization uptake rate. All the covariates were significant, as I mentioned, which was very exciting. The strengths of it, I thought that the BRFIS is a really strong data set. It's super interesting. I hope in the future to use it because there's so much you can do with it. It's really powerful and they're really nice because they format it for SAS. So that is a plus. The limitations, I don't know the generalizability of it because this is California only. It would be really interesting if we had more time and resources to expand it to more states and see if the same results applied. Maybe do other states with different Medicaid plans have better rates. I thought that would be really interesting if I had more time. I also thought there could be a little bit of selection bias because the survey respondents, nowadays everybody has scam blockers on their phone. Who answers the phone? What is the type of person who answers the phone and continues with a whole survey? And for no coverage, the difference is even more shocking. 81% are not vaccinated. 53% were not immunized, which was a little bit shocking given that insurance plans really advocate for this cheap and effective tool to prevent really costly issues later on. And for no coverage, the difference is even more shocking. 81% are not vaccinated. 53% were not immunized, which was a little bit shocking given that insurance plans really advocate for this cheap and effective tool to prevent really costly issues later on. And for no coverage, the difference is even more shocking. 81% are not vaccinated. 53% were not immunized, which was a little bit shocking given that insurance plans really advocate for this cheap and effective tool to prevent really costly issues later on. And for no coverage, the difference is even more shocking. 81% are not vaccinated. 53% were not immunized, which was a little bit shocking given that insurance plans really advocate for this cheap and effective tool to prevent really costly issues later on. And for no co So I thought that was an interesting fact. Some applications of it, I think health systems, insurers, and the government would all be really interested in this kind of data and see the really sad rates of influenza vaccination given the huge societal cost of the very preventable illness. And as I mentioned, I thought that future research could expand the analysis to several states and compare. And here are my references. And that's all.
Look at you. Is this the same person that was
Having a little bit of mental breakdown, yep.
Wow. Huh. All right. Questions, comments, clarifications?
Natalie, do you know why specifically, or like why you think public plans were doing well compared to the other plans?
You know, I don't know exactly why. I have some thoughts as to why. I didn't go into any research as to like actual concrete factors, but I would think that there's a lot more access to when they're there, they offer them for free or reduced cost. I know some insurance plans still charge you for the copay visit, the copay for the visit when you go get your flu shot, which is crazy. I'm lucky I have Kaiser. I rolled through a drive up and just stuck my arm out the window and got the shot, which was great. But for some private plans that are more expensive, I can imagine that would not be the case.
That's exactly why you would see it more in the public payers. It is also California. So California has developed a bit of a reputation for not being so great on immunization rates, which is super annoying because we're also the most populous state. So you're right on with comparing across states. And I had a quick question. Sorry, go ahead and ask your questions and I'll ask.
Also, I realized I shut out of the presentation, but let me know if you want me to pull up any slides.
Any other questions, clarifications, comments? I think there's something in the chat. Let's see what they're. More HMOs maybe? That's also a possibility. Yeah, for sure. So that's the capitation. Anybody else? Anybody? So I am curious to know, I would have loved to have seen that age, the older adults, because that's a big issue with immunizing older adults. But was this one of the optional packets of questions?
Part of it was. I think that I don't remember off the top of my head exactly, but I know I can pull it up in a second.
No, I forgot what they were called.
Yeah, the modules.
Yes, the optional modules or something.
Yeah, let me just pull it up.
Why don't you speak a little bit to that with Burfist in the terms of the design?
Sure. So they have, I think it's either 13 or 14 required modules that the states do. So it's a standardized survey, but then they have an additional optional number of modules that states can pick and choose which they want to do to customize it. A lot of states do most.
You guys hear me? Oh, drat.
Oh, your screen is frozen now, but we can hear you.
I froze, you guys. I'm sorry. I missed it. It's my internet. Did everybody else get it?
No, it froze.
Oh, all of us froze. Okay. All right.
It is not great up here, but anyway, there's optional modules and required modules. All the states have to do the required. They can customize it with the optional modules. And I think that influenza vaccination, I'm not sure off the top of my head, but I think influenza vaccination was in one of the required, but then some of the other demographic data, like who is your healthcare plan provider, is it public, private? I think those were optional, or I might have flipped that, but I can definitely give you more intel on that once I look at it.
Yes, that's going to probably be one of the comments, is just add a little line on that. So the fun part about questions is you get to speculate now, and I'm going to hit you with a doozy, which is, what do you think with these rates? How do you think California bodes for the upcoming COVID-19 vaccine?
So this is a tough one. I had the benefit of when I used to work for the state assembly, I worked for a member who was the chair of the health committee. And when I was working there, it was the vaccination debate about vaccination exemptions, and the sheer volume of messages and campaigns we got against us for that was really concerning. That was only 5 years ago. Given that, plus this data, I think it paints a pretty bleak picture for those outside of the required populations, not required, but in a sense required, like healthcare workers, nursing home residents. I really don't know that we're going to break even close to 50% of vaccination. That's my personal speculation.
And the reason that this type of work is so important is because it helps you know what to prepare for. Do you guys understand why the work you're doing is so critical now? This is the kind of work that she needs to present. You need to present this, by the way. I know you, I think you should. I strongly urge you, because this is the kind of work that informs decision makers, right? So they can see, oh, wow, even now, even this recently, these are still the rates of decision for a vaccine that is really old, efficacious, very safe. You know, this is supposed to be like a non-issue vaccine that's been around for eons, for the most part. Okay.
And people don't think that there's microchips in it or other crazy
microchips. Yes, exactly. Yep. Hadn't heard microchips, but I don't doubt it.
Oh, you have, that's a good one. We heard about that one back 5 years ago when it was the vaccine debate, the same stuff. It's just mind-boggling.
It so expensive to put any nanotech in a vaccine. Okay. So I doubt it. But anyway, okay. Thank you very much, Natalie. Great job.
Thank you.
All right. Who's next? Cynthia, are you set now? Are you good?
I'm going to just present it live because I don't know what the heck was happening. So, but I'm ready.
Totally up to you. Totally up to you. We got you either way. Okay.
All right. Everybody can see? Okay. So again, I'm Cynthia. I'm going to be presenting on my research question, does occupation affect self-reported health status?
Okay.
I ended up choosing the 2016 Health and Retirement Study Survey as my data set with Dr. Shabino's help. This survey data was collected using a longitudinal study with a 2-year follow-up. In order to understand the relationship between my variables, I wanted to run a chi-square test in SAS to test my hypothesis. The hypothesis I decided to test in the end was, does one's occupation and education level have an effect on their self-reported health status? I'm sure you noticed that there's a slight change in the initial research question and this hypothesis, and I'll talk about that later in my findings. So any of us that have had a job before understand that work can be stressful. However, different occupations present different challenges, and some affect your health more than others. So while doing my literature review, I found that occupations that require manual labor, like waste removal, maintenance, or landscaping, have a stronger negative effect on health status compared to occupations like accounting or computer science. In a study from 2016, I found that manual workers in the US are 50% more likely to die within a given year than workers in managerial, professional, and executive occupations. Initially, I chose occupation and industry as my independent variables, but after doing some more research and playing with my data in SAS, I found that education was a strong predictor of self-reported health status too. In a study done in 2007, I found that the better educated are substantially less likely to report that they are in poor health. So the data and results you'll see on the next slides will look at occupation, industry, and education level and their relationship to self-reported health status. It's really important that we understand which occupations present more hazardous or unhealthy environments so that we can implement interventions that can improve the health for these employees. So here's my table 0. I chose health status ranking as my dependent variable and education, occupation, and industry as my independent variables. For the sake of time, I'm not going to go through the specifics of this table, but instead I'll give you more insight on my table 1. That's the rest of table 0. It's really long. Okay, so this is my table 1. I created a legend in the right corner with color coding so that you can differentiate between different health status. After running crosstabs and creating this table, I began to notice patterns in health status between office occupations and manual labor occupations. So you'll see that low physical impact jobs like management, financial operations, legal, and education tended to have a higher percentage of participants who reported being in very good health, which is that light green color there. Unfortunately, an insignificant amount of participants reported excellent health, so that's why you won't see any dark green here. So on the other hand, high physical impact jobs that required manual labor, like serving, cleaning, construction, or maintenance, tended to have a higher percentage of participants who reported only being in good or fair health, which is indicated by the yellow and orange colors. Luckily, a very small number reported being in poor health, which would be the red. I went ahead and ran 2 chi-square tests to determine if there was a relationship between health status and microvariates, which ended up being education level and occupation. So industry kind of got dropped off here. Both tests indicated that there was a highly significant relationship, which are indicated by the red arrows. And I was able to reject my null hypothesis with that. In turn, that meant that occupation and education level definitely have an effect on self-reported health status. I will note that some of the cells had a count lower than 5. So it's possible that this chi-square was not completely accurate. And I did try to run a Fisher's exact test, but I ran into some problems with that. And it might be because my data set was so large. I'm not sure. But I did notice that the majority of the cells with 5 or less responses were typically in the category of refused to respond or didn't know. So hopefully they didn't affect my data very significantly. Okay, so this is my first graph. I decided the best way to display my results was with a bar chart. I collapsed my occupation variable into 3 categories. Office occupations, which are gonna have jobs like management, accounting, financial advising, and legal. On-feet occupation, which is jobs like serving or hospital support or protective services, where it's not super manual labor, but they're still moving around and not sitting at a desk. And then finally, manual labor occupations, which are jobs like cleaning, maintenance, construction. From this chart, you can tell right away that the manual labor occupation category has the highest number of fair and poor health responses, which are indicated by the red arrows on the right side. And then on the other hand, the office occupation category on the left had the highest number of excellent and very good health status responses, which are indicated by the arrows there. These findings were particularly alarming to me because the manual labor category had almost half as many overall responses compared to the office occupation. So the numbers were really alarming. This relationship indicates to me that employees in manual labor occupations report being in worse health compared to those in office occupations who tend to report being in very good health. So I also collapsed the education variable into 3 categories. So high school or less, some college, and college or more. I was able to tell that the high school or less category has the highest number of fair or poor health responses, which is going to be on the left. On the other hand, the college or more category had a very low number of fair and poor health status responses, which is the arrow on the right. This relationship indicates to me that employees who have completed a higher level of education typically report better health status compared to those who have only completed high school or less. So I believe that my findings were definitely in line with my hypothesis. However, during my research, I also found that education was very important, a predictor of health status. This was consistent with my literature as well. Some strengths of this project and research are listed here, but I'll just share a few. So with Dr. Shifino's help, I found a really large and thorough data set with tons of survey data, which allowed me to easily and quickly compare different variables to health status. However, my data set was a bit difficult to import, which set me back quite a bit in the beginning. And the size of my data set also caused a lot of lag during my data steps in SAS. That was kind of frustrating as well. In regards to the literature, I found a lot of literature on the relationship between education level and health status, but I had a much more difficult time finding literature about the relationship between occupation and health status. A lesson that I learned during this process was to try different tests and data visuals to find the best fit for your data. Also, don't be afraid to ask for help or look for help. I was able to find some SAS code and troubleshooting help on Google, but also Dr. Shafino and a few classmates helped me along the way, which I'm super grateful for. This was definitely a trial and error process, and I learned a lot. Thank you very much, and I'm ready for questions.
Very good. Questions, comments, clarifications? Can you put up your table just so we can start there? I have a question there.
Table 1 or 0?
Table 1, but the header of table 1.
Okay.
So is that industry or is that occupation, what I'm looking at here?
Oh yeah, sorry. I gave it the raw variable name. This is occupation here, this first one.
Okay, okay.
Yeah.
Yeah, that kind of threw me off.
Yeah.
All right, questions, comments, anybody?
Question. Cynthia, is this table 1? Is this your chi-square?
Crosstabs.
I see. Okay. I couldn't see all the way to the right, so I didn't know if there was like a p-value on the end there.
Oh yeah, no, those are going to be here.
Got it.
So I have a question about that. Oh, I see 138 degrees of freedom. So you did leave them all in there, didn't you? You left every category in there?
Yeah.
So you made a huge matrix because it multiplies each occupation by all 5 outcomes, right? So if you go back to your table 1.
Yeah, all the 5 at the top.
So do you see how management times excellent, very good, good, fair, poor? That's 5 per value. So that's 5, 10, 15, 20, 25, 30. Do you see what I'm saying?
Mhm.
So, So, but when you look at your histograms, you categorize this table, right?
Mhm.
Okay, that's what you want to run for your chi-square, the categorical variables.
Okay, after they've been collapsed already? Okay, gotcha.
Because you did excellent. So go back to table 1. You did a great job in figuring out how to cut or how to classify the on-feet office or low impact, medium impact, high impact work. I actually like the manual one because this is a really good way to classify these. You almost did like a mini, like a manual principal components analysis, which is pretty dang cool. So yeah, but what you would want to run is the chi-square on the collapse variables, because then it's just basically 15 degrees of freedom, right? So it's 5, 10, 15, because it's
yeah,
5 versus look at your chi-square, look at your degrees of freedom.
Yeah, there's a lot, 120.
120 and then 138. And if you still have less than, and then you would not have less than 5 in a cell. If you still had less than 5, then the fissures would work. But yeah, that many degrees of freedom is going to be like it. Yeah, it would be a doozy.
Okay,
for a fissure.
Thank you for that.
I'm impressed that you tried to do it.
Yeah, the Fisher's test was not working at all.
I don't even know if you can do it with that many degrees of freedom. To be honest, I've never even tried that. So now we know.
Yeah, that makes more sense. It just kept loading and loading and loading. So I'm like, okay, maybe it's just too much data, but that makes sense now. I had too many.
Imagine your computer started smoking.
Yeah.
All right. Any other questions, comments? All right. Very nice. Very nice. I've never seen the methods up front like that. I kind of think it was interesting. I kind of liked it. I was like, oh, oh no, she forgot the background. Nope, there it is. I kind of like it. I've never seen that. And I'm like, oh my gosh, I wonder if I could pull that off.
I think it's because I ended up changing them a little bit, like to education. So that's why I ended up putting it first.
But there's no rules in that respect. There's tradition and norms, but there's no like law. So, I'm like, oh, that's kind of cool. Because you kind of prime your reader. So
yeah.
All right, who's up? We're actually making fairly decent time.
Dr. Shapino, may I go next?
Yeah, go for it, of course.
I have a recording, so let me see if I can put that up.
Yeah. I'm not texting. I'm resetting the clock.
Oh, you're fine. I wasn't even paying attention to that.
Hey, like if you guys see me on the phone, I'm like, oh my God, this looks terrible.
Alrighty, so I'm gonna press play right now. I'll be discussing the relationships between
You're in your presentation.
I'll be sharing some background information and research evidence and the data set that I used.
Can you turn it up, Twee?
And analysis to compare the literature that I looked at. And lastly, what I learned throughout this research process. So why does this relationship matter between food insecurity and childhood obesity? Well, it's a public health concern, and there's growing evidence that childhood life stressors or first childhood experiences are associated with obesity in the United States. More recent data has shown that about 31% of children in the US are either overweight or obese, and those rising cases are reflective of increased cases of comorbidities when they're adults. So type 2 diabetes, hypertension, and non-alcoholic fatty liver disease are some of the data listed. The map below shows the percentage of children who are overweight or obese across the US. The deeper the color, the more prevalent these cases are. And the pyramid that's below me, or on the far right, is Saturn's hierarchy of needs that I based the framework off of for my research topic. That's based off of Maslow's hierarchy of needs. And I wanted to explore whether there's an association between food insecurity and childhood obesity in the US for kids between age 0 to 17. So it's rather broad. We'll give you a moment to take a look at that question, and that's my PICO. The data set that I selected was from the 2019 National Survey for Children's Health for the NSC by the US Census Bureau for several years now. The NSCH is an annual self-reported representative national survey that collects a range of indicators regarding child health and well-being, from physical to emotional and mental health. This is a cross-sectional descriptive analysis of the survey. They utilized randomized telephone calls into web-based surveys. The population sample consists of children between the ages of 0 to 17, and the responses are provided by their caregivers, their parents, or legal guardians. And based on my variables, the sample size I observed was 29,433 responses. And the variables on the left are what I thought to be most appropriate to my research question, while the variables on the right were a little bit more tangential. And yeah, I'll consider these for possible future values and variables to look into my literature review. But these are the tables that I formulated based on what I looked at through that 29,000 plus responses. So these are the ones on the left is a more generalized capture of my variables that were independent covariates. And it's reassuring to see that the majority of the responses were of normal weight. But when I combined like the literature I read of overweight or obese, was at 20%. So although it wasn't at 31, it is alarming to see that it's over children population in the US to be that high. And while there was a substantial percentage of respondents not enrolled in WIC or food stamps or other assistance programs, there is a 16% response rate that households who rely on these programs and nutritional support over the past 12 months. And the table on the right, table 2, is a crosstalk between my independent variable and case factor to the outcome variable with some covariates. Although I did collapse the how to cover basics like food and housing from 4 categories to 2, I wanted to encode it to have more impact between low and high risk for more conciseness. And moving on to the chi-square, I observed that there is a statistical significance between across the outcome variables and the independent variable, and the histogram depicts that there is a positively skewed distribution. This indicates that there's
Oh, we lost her. Shoot. All right, stay tuned, guys. She'll be back in just a smidge. Wow. I didn't realize food insecurity was such a significant covariate. Everybody's so quiet.
That's so sad. I was like, no.
I know, it's like, poor thing. And she's gonna be the most upset because I know everybody else is like, we'll get it. And I know she'll be like, but hopefully she's still not tapping in.
I texted her to let her know.
Yeah, no rush whatsoever. We can even start someone else if she feels more comfortable. It's totally fine. Yeah, I don't want you guys to sweat any tech difficulties whatsoever. This stuff happens. Who is left, by the way? Who do we have left? I've got most of it.
I can go next.
5. Who said that?
Judith.
Okay, so we got Judith left.
I'm left too.
Jake, you're left too. Okay.
Hey guys, so sorry. How
Oh, there you are. Are you good or do you want?
How long was I gone for? Because I was still playing the video. And then I saw you were like just like in deep, deep thought. I'm like, she hasn't moved. No one's moved. And then I got a text.
You were telling us you had your table up.
Oh,
I was
my.
studying your table. Actually, yeah, she was at that slide, right?
Okay. Let me go. Did you see a visual of anything? Like the histogram?
Yes, the histogram. I was looking at the table next to the histogram.
Okay. Oh no. Oh man, my internet is unstable right now. Sorry,
Do you want a minute and have somebody else go?
I mean, I have about three minutes left. I'm gonna see if I can turn off my video, and hopefully that'll work because I can't really.
Totally up to you.
Alrighty. Okay. Is it okay? I'm sorry, Jake. I think I didn't know if you were going next, but I can go after you if.
No, go ahead, Twee. You're fine. You're fine. If it's loading, let's go for it. You're totally fine.
Okay, thank you.
Hey, it happens. Remember when I kicked you all out of class at the beginning of the semester? It happens
Really?
to all of us.
Oops. Alrighty. Oh, okay. Let's see. All right.
There you go.
Here we go.
Public assistance programs such as WIC or even SNAP. And this is consistent with my the literature findings that I was looking at and reading, that the exposure to one or more ACE factor is associated with higher BMI-Z scores, therefore for optimizing early childhood environments can impact obesity risk by reducing food insecurity. And I had and obstacles came across. So some of the strengths was that the NSCH was quite comprehensive and updated with their code books and surveys. So I had no really issues with syntax and adding that into my SAS coding. Also the interactive table for the national outcome measures provided some confidence in me that my histogram looks similar to that distribution. But some of the limitations, and it was a huge caveat, was that the captured BMI percentiles were for children ages 10 to 17, and I wanted to look at the scores for children 10 and under. So I might have skewed the data to where I'm like, oh, I guess it's a positive association, but it wasn't exactly what I was looking for, hence I broadened my research question. Also, the design of the survey was retrospective, less controlled. There could have been some unintended consequences, such as recall bias and antecedent consequent biases that the respondents provided on behalf of their children. And with that, there was some challenges in establishing the appropriate framework to my research topic. But my final thoughts through this, the accessibility and equity are essential with these healthcare milestones and these assessments to improve health outcomes, and that the perception of the responses could be different and can skew the reality of what the reports are for these variables such as BMI percentile. And so what I do want to, moving forward, I do want to have more comparisons between different data sets and different databases early on to see the compatibility of my research question. And now with the action plan, there is currently in South Carolina, the SNAP program, they're more in tune with using these nutritional assessments to help decrease childhood obesity in their state. This is the literature, my data dictionary that I created, and the interactive table from NSCH's website. Thank you so much. And I am curious to hear what your thoughts are and what your questions are. Take care now.
All right. Oh, you're muted, Dr. Shafino.
Questions, comments, clarifications. Sorry, I was swallowing and breathing at the same time.
Okay, I gotta. I think my camera is freezing, so I'll just keep my mic on, but I'm present.
Do you have the slides? Because I would like for you to bring back the tables, table one specifically. I want to be able to see that.
Yeah, let me pull up my slide really quickly. Presentation. Now let me share my screen with you. I'll just, oh wait, sorry. My slides. Just do one.
All right, while you're doing that, I'll ask you a general question. So one of the questions was, you indicated that which of the variables was the ACE? I wasn't sure. The ACE factor, which was that the hard to cover basics like food or housing?
Yes. Yes.
Okay.
Yeah, that was. Go ahead.
No, I was just gonna say when. So high risk and low risk. What exactly did that mean?
So it was originally categorized as like 4 categories, but I didn't go into detail in the video. But it was like 4 was, you know, we had enough, we have enough to afford good nutritious food. And then as the numbers went down, that means like the more difficult it was for that household or for that family to afford nutritional foods. And so when I recoded it and collapsed it, I put the lower scoring, it was kind of inverse, but I put the lower scoring as a high risk and then the higher scoring as
No, that makes
the
sense.
low risk. Yeah. Mm-hmm.
Wow, and 13%. That's a lot.
Yeah. It's pretty alarming. But with my internship, it does kind of I know it's anecdotal and like these correlations are kind of like loosely based, but I do see these types of struggles that some families are facing, especially during this time. And so like that percentage just
Oh,
sort
no,
of mirrors
it's
that.
really bad. It's really bad.
Yeah, especially with COVID these days. Yeah.
Okay. Any questions? Anybody? Before I ask more? You guys are tired, aren't you? So the other question that I had was with respect to your framework. So you said you
Yes.
didn't have a framework, but I mean, it looks like you nicely aligned to the nutrition framework. So I mean, I wouldn't say that you didn't have a framework because I think it made a lot of sense in terms of nutritious food and enough food.
When I was looking through the literature, and I do appreciate that, I was able to find some studies about it, but it wasn't regarding, it was like regarding just like the food type. It wasn't regarding the adverse experiences that these families were having. It wasn't based on like income or anything of that factor. It was more like, okay, well, are you eating well or not? So I wanted a little bit more.
Well, keep in mind that you can adapt a framework to your interests, right? So if you contextualize the nutrition framework, then you can indicate the reason that enough food is at the bottom is because of these income and adverse effects. The reason that, so as you know, the shifting from one level to the next is not due to just food, it's due to these other intersectional factors that are related to the social and demographic context.
Okay. All right. I feel
So, you know, in that respect, but it's always good to start with some evidence-based baseline that helps you move forward. Okay. This is really nice. And it's really, really interesting. I actually, one of the findings so if you look at your table, oh, this is bigger. Good. I can see this better.
Yeah.
I was surprised by, there was one, oh no, it's on the other slide. Go back.
Oh, let me go back.
That was saying like, where'd it go? Oh, like for example, which one was it? Oh, maybe not. Oh, that makes sense because it's WIC. Oh no, it is. Okay, so see how they said that they are not on WIC, but are have a lower proportion that are high risk.
Yes.
No, that's not the one that was intriguing to me. Sorry, I can't remember which one it was now. Dang it. Which one was it? Okay, I'll look at it later and tell you. I can't remember now. Oh, one that was really interesting was the obesity and high risk. That one was that's one of them that stood out. So can you tell me, what do you think about that?
I mean, regarding like this was like I tried to make it as cohesive with what I was looking at, but I wasn't, I mean, as sad as it sounds, like I wasn't really surprised given that like the caloric and nutritional density of poor foods is more affordable to some of these households.
So it's that hypothesis. Okay.
Yeah.
So that's supporting that. That's good. I mean, it's not good, obviously, but I mean, that's definitely, instead of it just being something that people say, you're literally showing like there is truly a lack of access to nutritious food. So it's not just a question of food, it's nutritious food.
Yeah, like these food deserts in some of these areas are quite real. So I wanted to look at like city areas, but obviously I didn't put that in into this study.
Okay, so that's something you could do though, urban rural, maybe, for example,
Yes.
or, I mean,
Absolutely.
urban rural is so big, but it's something.
Yeah.
All right,
Yeah.
very good, very good. Okay, thank you.
Yeah.
All right, who was next? I have Judith and Jacob.
Yeah. Let me share my.
Sorry.
And then, is that all? Are you two my last hurrahs for the day?
I think so.
Okay. Thelma is going to be sending a recording out, so hopefully if anybody can review that, great. She had a small emergency, so she is unable to join us today.
Can you see my screen?
Yes.
Okay. So my research topic looked at the characteristics of ER visits for asthma. And so just a brief background, I really wanted to highlight disparities in asthma prevalence. Research has shown that minorities experience disproportionate rates of asthma morbidity and mortality. And there are also factors that contribute to disparity. Primarily, there are environmental factors. So one study found that the burden of asthma disproportionately affects children living in economically disadvantaged urban communities, and that there are greater exposure to environmental triggers and absence of regular asthma care all contribute to disparity. They also found out there's traffic sources that contribute to the development of asthma as well as the exacerbation of the symptoms. And so in terms of literature and significance related to specifically ER utilization, so the research that I found was that racial and ethnic disparities in asthma medication management and healthcare utilization are present. So one study found that Black and Hispanic children compared with white children had more indicators of poorly controlled asthma, including increased emergency healthcare utilization, more daily rescue medication use, and lower use of ICS, regardless of symptom control. In addition, there are barriers in access to primary care that influence ER utilization, asthma care management. So one study also found that parents expressed strong preference for primary care treatment and identified real perceived difficulties in primary care as the principal reasons for ER use. So why is this significant? So the persistence of disparities in asthma prevalence and asthma control leads to increased costs and detrimental health outcomes. So identifying the risk factors or characteristics in ER utilization can help to develop solutions and interventions for populations that are more at risk. So my research question is, what are the characteristics of those that visit the ER for asthma? So my study design, my data source. So my data source included 2017 National Hospital Ambulatory Medical Care Survey. And the most recent data that I could find was on 2017. And so my study design was a descriptive study. And in terms of my independent variables, they were age, sex, race, ethnicity, pair, and my dependent variable was reason for visit equals to asthma. So I'll also discuss how that was one of my limitations. So sorry, Professor Shafino, I had the tables broken down into the same slide, but for table 0, I looked at, so there's differences. So in table 0, I looked at the prevalence of asthma, because when I was initially looking at the data, I found that there was a survey question that asked, does the patient have asthma? So this doesn't necessarily indicate that the patient came in for asthma, but what was interesting was to find was, initially I thought that asthma visits would be a large significant number for ER utilization, but in fact it's only 10% compared to non-asthmatic related ER visits. Yeah, so, and then looking at specifically at the patients who do have asthma, so if they said that they do have asthma and they came into the ER, a few interesting variables was that looking at age, so it was between 25 to 44 had a greater proportion, and looking at ethnicity, non-Hispanic whites had a greater ER utilization and had asthma, but not specific to asthma, but they had asthma prevalence. And then looking at table 1, so this is where I changed things. I was really looking to link specific visits for asthma. So I approached it different ways. And finally, I ended up with linking it for reason for visit. So in the survey, a patient can list out the reasons for visits for their visit up to 5, and then we'll label it according to their main concern and why they're visiting the ER. So for the variables, they were all significant except for gender. So age under the 15 had higher utilization for ER in relation to asthma, as well as ethnicity and payer type. So for ethnicity, non-Hispanic Black had a higher percentage. And then for payer type, Medicaid or CHIP had a higher percentage. So then displaying this information in a graph format, you can see that non-Hispanic Black who had a reason for visit for asthma had a larger frequency. And then looking at ER visits that were not related to our reason for visit to asthma, we can see a difference where non-Hispanic White actually have higher utilization of ER visits. And then again, reiterating for the payer type, Medicaid or CHIP, so that was a significant pair for patients who came in for asthma-related circumstances. And that's for the research. So just to reiterate, so the results from my research question are that there's a higher utilization for ER visits among patients under 15. There's a higher utilization among non-Hispanic Black, and then there's a higher utilization among patients with Medicaid or CHIP. So what are some insights? What does this tell me? What is the wisdom? Why is this important? So we can clearly see that there's a disparity in ER utilization across ethnic categories. This indicates that there can be underlying factors that may be contributing to this disparity, not only in ER utilization, but possibly asthma care management. So for Black patients may encounter greater barriers to receive an asthma care management, which influences ER utilization. And a lot of the research that I found concluded that ER utilization for asthma is largely preventable. So this can lead to higher Medicaid expenditure and costs for hospitals and patients, as well as this information in terms of their quality measures. So I think for the Joint Commission, asthma is a core measure, as well as for HEDIS, it's an asthma measure. So knowing that this disparity exists can definitely impact quality. And so knowledge to action. So this research can help formulate and identify interventions that are focused on populations with higher ER utilization. It can help identify factors and barriers that contribute to the differences in utilization among patient populations. And it can lead to systemic changes in healthcare access, primary care access, and asthma medication management in primary care. So some next steps could be doing a needs assessment, really understanding why there's this disparity, why there are these differences, and then implementing intervention such as discharge planning, care coordination, medication management, health education, things like that. So initially, my initial research question was looking at interventions, but then I had to change it more on the descriptive statistics because that was the data that was available. So some strengths and limitations. So some of the limitations, it was challenging to link ER visits for asthma because RFE is limiting. So I first started looking at diagnosis. So of those patients who had a diagnosis for asthma, but the patient population was pretty small compared to RFV. So I just ended up going with RFV. And then I couldn't find specific asthma-related conditions that prompted ER visits. And additionally, another limitation is that there could potentially be a selection bias of those who filled out this survey. And then strengths, although it was difficult to link specific visits for asthma, after I figured it out, I had the opportunity to look at asthma-related visits rather than asthma prevalence. And then some future research. I would be interested to know ER workflows that help reduce readmission rates, workflows for transition of care, patient follow-up, and case management and care coordination interventions. And then those are my references, and thank you. Thank you for your attention.
Very good, very good. All right, questions, comments, clarifications. Wow, y'all are on time this time.
Judith, I don't know if you mentioned this, but did you look at location, like urban versus rural?
No, I didn't. It was just a national data set. So that would be another future research as well. I would be interested in looking by state, like which state has a higher asthma prevalence and higher ER utilization.
Does it have urban rural?
I didn't check. Yeah.
I know it has regions, so it has humongous regions for the public use, but you can actually get in the in the restricted data set, you can actually get like zip codes. So that would actually be pretty cool.
Oh, okay.
You have to request it, but I can request it for you if this is what you want to pursue. So it can be done. And that would be a really great location of care to look at. Because there certainly would be something there. So,
Yeah.
good question, Tamron. Anybody else? So I know you're going to know that I'm going to say row percent.
Yes.
Because I can't compare them. And I noticed that everyone's histograms have frequencies. I'm not going to ask to change it, but just in the future, think proportions if your baseline sample differs. It just helps you compare more. Much like Justin converted everything to rates per 10,000 or 100,000 for comparison. We need to do the proportions. That just helps you guys compare more. I have a question, Judith. When you said specific, well, I have two questions. Was usual source of care asked? Because I wonder if part of the reason, and tell me what your thoughts are on this, that that the ED visits are so prevalent is because patients lack a usual source of care. Now, I feel like I've seen that in the evidence for sure. Actually, I know I have. So I'm just wondering if you're able to tease that out in this data set.
Wait, can you repeat that one more time, please?
If patients report a usual source of care or a primary care provider.
I didn't explore that in the literature or the survey.
Okay, so that's something that you could potentially look at because that would be associated with care coordination and case management.
Okay.
Okay. And that should be in literature too. So definitely note that. And then the other question, you mentioned in your limitations, specific asthma related conditions. Can you explain that for me? I wasn't sure what that meant.
Yeah, so I meant like what symptoms were they experiencing in relations to asthma?
Oh, so the reason for visit, the doctor put asthma, but you were curious about what kinds of symptoms brought them in?
Yeah.
Oh, interesting. And why were you curious about that?
Just interested to know because a lot of the research were saying that it was highly preventable, these visits. So just in terms of that.
Oh, like how bad it was that drove them to come in?
Yeah.
Are you suggesting that maybe it's kind of a lack of knowledge of what to do?
Oh, no, I wasn't suggesting. I was just curious.
No, what I'm saying though is if potentially a person knows that whatever's happening, they can actually manage it versus not knowing how to manage it.
Oh, absolutely. Yeah. If they have that education, definitely.
Yeah. Okay. Interesting. All right. Thank you.
Thank you.
And last but absolutely not least, Mr. Bramwell, please.
Yes. Let me pull up my
Thank you for your
slides.
patience.
Yeah, and thank you too for your help via email. with
Of course.
clarifying everything, making sure
You
it's
guys had great questions. Oh, I'm going to be sad after this presentation.
all right.
Oh, I like that title too. I have good titles. To ask you for titles for my papers.
Okay, can everyone hear and see this? Okay, great. Okay, so let me start my timer real quick. Hang on a sec. I almost forgot.
All right. Well, I have this one going, but none of you have gone over yet. But the annoying sound is here.
Okay, I'm gonna start mine right now. Okay, the future of prenatal care, how group visits impact prenatal care satisfaction. So for anyone that doesn't know, prenatal care is the care that is delivered to pregnant women before they give birth. A little background into why I wanted to research this. The problem here to be solved is in light of the triple aim, traditional models of prenatal care are resource intensive, which means they're really expensive. COVID-19 as well, when it hit earlier this year, it changed the landscape of healthcare. And a lot of providers, administrators, and these healthcare organizations saw this as an opportunity to possibly reconstruct some of these more resource intensive workflows to better achieve the triple aim. So I'm focusing this on the reconstruction of prenatal workflows. On the right here, you can see that the circle here is prenatal care, and each of these different shapes represent possible ways that providers can supplement or improve the traditional model of prenatal care. So remote patient monitoring is one way that they can, they can implement this into traditional models of care to improve the prenatal care and possibly reduce utilization costs. So each of these just represents ways or alternate prenatal care models. So for the purpose of this study, I'm focusing on group visits, which is pregnant women meeting together in person with a doctor. Background to be continued, there is some literature that has been looking at reconstructing traditional prenatal care models before COVID. So this first one here, the group prenatal care and patient satisfaction study actually found a correlation with group visits and increased patient satisfaction. With that finding, I was anticipating a similar result with my findings. This is another article by the Mayo Clinic that pulls in really all aspects of the care that you can see here. So they pull everything in together. But again, I'm just focusing on group visits. The framework used in the study that I did is called REAIM, REAIM, which entails these different concepts. The one I'm focusing on is REACH. And REACH is tied to really a more focusing on the population that it represents and the generalizability of my findings. The research question is, how does additional peer support through group prenatal visits impact a pregnant woman's satisfaction with care? Moving on, this is a quick overview of my methods. So I did find a national survey. It's called Listening Mothers 3, because other research that has been done did not focus on a national representative sample population. So that is kind of what's unique about my study here. The literature that I previously just announced was they looked at just specific health organizations and how group visits impacted patient satisfaction with their prenatal care. So this study really looks at a national sample of pregnant women. And that really is what adds value to my findings. And then sample population, there are 1,072 women. You can see the breakdown on the right. There were 2 surveys given. There was an attrition rate of 45%. So we did lose a significant amount of women between survey number 1 and survey number 2. If you're interested, survey number 1 was given before they gave birth, and survey number 2 was given after they gave birth, so postnatal. And then they were awarded a gift card for completing surveys as an incentive. And then over 1,000 variables were collected. So this was a big data set, and it was kind of fun to sift through it all. So, okay, for my analysis, so I did do a chi-square to compare differences between groups. I did this for my variables that were categorical variables, which are group visits, race, marital status, insurance type, and doctor type. Again, I'm interested to see if each of these variables impacts prenatal care satisfaction, and if group visits is still significant in impacting prenatal care satisfaction when each of these are present. Whoops. So I did do a t-test for my my continuous variables, and then my logistic regression was pulling all of these variables together to see if I still have significance with my main outcome variable and my main, or my outcome variable, my main independent variable. This is a picture of my table 1. So a couple key takeaways from this. Only 11% of the sample chose port-a-fare This is an error on my part that should add up to 11%, and I'll fix that for when I submit this. But just know that most of the sample were satisfied with their care. Only 20% of the sample participated in group prenatal visits. You can see that here. The majority were not. They just went in solo with the doctor. And then again, this sample is more representative than other studies, and you can see that here. There's a good showing of Black African American as well as Hispanic and Latina patient participants in these surveys. And then more than 75% of women visited with an OBGYN directly. That's down here. I thought that was interesting. Moving on, I just wanted to show this histogram. Again, it further illustrates the difference between these groups. So you have over here, the majority of the population was satisfied with their care. And then the blue bar is higher than the red bar in each group, which just indicates that the majority of these, the sample were not participating in group visits. Okay, this is my table number 1, which is a chi-square. And I wanted to just point out a couple of findings here, because all of the covariates except education level were significant between groups. So for the first one here, you can see that women who did not participate in group prenatal visits, which was 92% of them, were more likely to report being satisfied with their prenatal care when compared to women who did participate in group prenatal visits, which was at about 78%. And this difference between groups was significant. The only other one I wanted to point out down here is with age as well. And so age as well, you can see is significant. And so we'll get further into detail here on my logistic regression. Okay, so first off, looking at what is significant, age is significant, as well as group visits. So that was exciting. Well, what does this mean? So group visits were significant in predicting patient satisfaction with care, but by how much? So looking down here at the point estimate, we see that pregnant women participating in group prenatal visits have significantly lower odds of being satisfied with their group prenatal care compared to women not having group prenatal care visits. So this is opposite of the literature from what I found, and I'll get into why in a minute. The other one I wanted to point out is age. As age increases, pregnant women are more likely to be satisfied with their prenatal care. Discussion. So why were my findings not aligning with the literature? One possible reason for this is Likert scales tend to skew. I did actually collapse my Likert scale variable into a dummy variable. It just makes the finding not as specific. Another reason could be that the sample does represent a national level where other literature did not. And then additionally, age is a predictor of satisfaction with prenatal care. That is consistent with the literature. It could be that mothers first time giving birth, so they don't know what to expect. Typically, them giving birth, they're younger. And then action steps. So health systems implementing alternative prenatal care programs should carefully consider group visits as a sub-intervention.
Very good.
Strengths of this is the national sample is, again, there's a national sample of pregnant women. That's what I used. Some limitations is time needed to do further analysis on my chi-square like post hoc tests. And other articles I found measuring patient satisfaction actually used a continuous variable for more precise measurement. And future research could look at qualitative aspects of group visits, why they're appealing to patients, why they're not, as well as possible social media or online groups and how that might affect patient satisfaction with care. And that is it. Thank you so much for paying attention and listening, hopefully. If you have any questions, feel free to ask.
Very nice. Very nice, Jake. All right. Questions, comments, etc. I know you get tired of hearing me say that.
Hey Jake, that was awesome. I would like to get a little bit of clarification on what you mean by like a sub intervention for health systems to implement to kind of like improve these programs.
Yeah. So the intervention could just be, so it kind of goes back to this slide here. So healthcare organizations that want to find an alternative prenatal care model that is less expensive but still efficient and effective in its purpose, they might decide on an intervention. And right here in this article by the Mayo Clinic, can you see that, called the OB Nest?
Yes.
So that's considered an intervention. By implementing the OB Nest, they want to test to see if this alternative model of care actually does what they want it to do compared to the traditional way. And then each of these aspects is included in the OB Nest. So these are what I'm calling sub-interventions.
Okay, thank you.
Yep.
Jake, I kind of thought you meant tailoring too. So like thinking about like certain age groups and certain, because I mean, I completely agree, but I also think, you know, like this happens a lot with many interventions, is that one size does not fit all. And so the RE-AIM framework is a very popular stable dissemination and implementation framework that helps organizations understand that one size does not fit all. So it helps them see that, you know, how will this intervention work and what is different about my target population. So one of the questions that I was going to ask you is, what did the literature that you did look at, what did that population look like? Because your population was very it oversampled on minority women. So I'm curious to know the literature that you looked at, what was their population distribution, so that you can glean from that, hey, I think, you know, this actually would work better for a more diverse sample, or does not work good for a diverse sample. And so what you're saying is excellent. So like doing a mixed method analysis.
Right. Yeah. So, and to your point, although sub-intervention didn't mean what you thought it did, I covered your point and just this part carefully considering, because in the literature, both of those studies actually, well, the one with the OB Nest was done in an academic medical center. And so all of the participants were employees of the academic health institution. So that's going to be, you know, higher income. It's going to be less diversity. And then very similar to the other one, it's, you know, the sample was restricted to just the health system, the two health systems that were being compared, and not as representative. I could go look into exactly what the diversity was,
or the population really, but that doesn't mean that that intervention isn't good. It just means that that's an excellent like occupational health intervention that even a company could implement, right?
Right.
Like for employee health, but it may not necessarily work in the community. And so that's what you are analyzing here is really important in that respect, because this is exactly what dissemination and implementation research is intended to do. It's intended to show us, you know, will it fit for
just
whatever.
because it worked over here, you know, in this state, doesn't necessarily mean it's going to work in the real world in each of these different, you know, community-based clinic systems or wherever it's being implemented. So just be careful, and
yeah, exactly. This is and that's the strength of it. That's a huge strength of this type of analysis. So very good. Anybody else have any questions or comments? So one other thing, and you don't have to do this or anything, but I would have loved to have seen a stratification or an interaction term. And I know you don't, I don't know if I didn't teach you this, but where you interact satisfaction and the group visits, and go back to your table one. I'm trying to see which one. So like you stratify it so that both are an outcome. So that you would do satisfaction with prenatal care by group visits. So it's like satisfied, not satisfied, group visits, yes, satisfied, not satisfied, group visits, no, satisfied, not satisfied. So it's like a stratification. And that's just a by statement. I don't know if you had enough sample to do that, but I feel like that would be really interesting as well. Because then you could look at all the covariates across those 4 groups, as opposed to just the satisfaction in general.
So that would tell me, like, it would give me an idea as to the relationship between all of my other covariates and group, who chose basically group visits. Yeah, that would be really interesting.
And satisfaction, yeah, because then it stratifies it by both of those factors. Yeah, it's pretty cool.
That's possible. So
I can show you. I can show you how to do that if you want.
Okay.
I mean, you're good. Don't do that for your. You're good. Please don't do that for your final. I'll note it in the feedback as optional. I did that for everybody, just because I have a wish list for you guys. For those of you that may consider presenting your research at SRS or some other. So that's all of you. I'm talking to all of you. But that's it, guys. That wraps up our semester. You did it. I am so over the moon proud of you. You guys can all list on your CVs, beginner/intermediate, however comfortable you feel, of SAS 9.4. And that is a skill. It's a big skill. So list it proudly. And thank you. Thank you so much for taking this journey with me. I'm really proud of you guys. All right, that's all. Stop being a cheese ball. This is my first time teaching this class and you guys delighted me. So thank you. And don't forget me next semester. You can always still come see me. I'll have office hours and whatnot.
Even if it's virtual, are you okay with virtual office hours?
I have virtual office hours after this class. Next semester will oh, my baby! Next semester will probably be on Mondays afternoons. You guys have class on Monday afternoons? If so, I'll make another hour. So. Okay. Oh, he's sleeping?
Yeah.
Oh, he looked passed out. He just ate, huh?
Yeah.
All right. Well, thank you guys. It has been my privilege.
Oh yeah, wait, Dr. Shvina.
Yes.
I tried to submit the feedback for today using the old place to do it, but it wouldn't let me like open the quiz again to like submit it.
It wouldn't?
Yeah, I didn't know where to go to like
did have a question on it.
Yeah. So
it's only showing one question, so there isn't a question 2, at least for me.
Did you submit question 1? Let me stop recording.
I did.